Welcome to Section 3, Part 1 in General Principles. In this part, we will discuss sympathetic and parasympathetic receptors. So let's get started. In Section 2 of this chapter, we discussed second messengers using Table 1.1. In this section, we will elaborate on the specific actions and functions that each of these receptors are responsible for. We will first talk about sympathetic and parasympathetic receptors, such as alpha 1, muscarinic receptor 1, muscarinic receptor 3, beta 1, beta 2, muscarinic receptor 2, and alpha 2. And we will approach these receptors from a holistic standpoint so you can see what happens to the body as a whole when these receptors are stimulated. In the last portion of this section, we will discuss histamine receptors and vasopressin receptors, so H1, V1, H2, and V2. Now let's jump into autonomics. There are sympathetic receptors and parasympathetic receptors. The sympathetic receptors are alpha 1, alpha 2, beta 1, and beta 2. Now, norepinephrine is the primary sympathetic neurotransmitter, which means this is the thing that is released from the presynaptic neuron. Epinephrine is released from the adrenal medulla and can also stimulate the beta 1 receptors. And we'll elaborate more on what norepinephrine and epinephrine can act on the next slide. Parasympathetic receptors include M1, M2, and M3. And understand that M stands for muscarinic. And the neurotransmitter used for the parasympathetic nervous system is acetylcholine. Now let's look at figure 1.14 and see that we have three general receptors in this figure. So let's first focus on the parasympathetic pathway. You can see these in both the top and bottom part of the figure, which are the sources of the parasympathetic neurons. You can also see that we have the sympathetic pathway as well as the somatic pathway. Now this figure is worth memorizing. However, in this lecture, we will help you know how to apply the various pieces of this figure, making it much easier to remember. Notice that there are preganglionic fibers and postganglionic fibers. So we'll write pre right here. You can see that all the way down. We're going to skip the somatic for now, and then we have the postganglionic neurons. Notice that the preganglionic neuron will release acetylcholine as a neurotransmitter. And that's true all the way across the board. And now let's focus just on the parasympathetic nervous system. Notice that acetylcholine is the postganglionic neuron. We'll see that at the top and the bottom. And that's the rule. Acetylcholine is the postganglionic neurotransmitter for the parasympathetic nervous system. And recall that the muscarinic receptors are the receptors of the parasympathetic nervous system. So acetylcholine will act on M1, M2, and M3. And we can see that again at the bottom, M1, M2, and M3. We will discuss the specific actions of M1, 2, and 3 later in this lecture. For now, just get a basic understanding of what acetylcholine will act on. Now let's focus on the sympathetic pathway. Now, the sympathetic fibers originate in the spinal cord at levels T1 to L2, as we've written on this figure. Now, the preganglionic neuron will release acetylcholine just like in the parasympathetic nervous system, and it will act on the nicotinic receptor. And the N stands for autonomic. So you're going to see two nicotinic receptors. One that says N, that stands for autonomic, and then there's M, which stands for muscular. And the only time this NM is relevant is down here when we're talking about skeletal muscle. When focusing on the preganglionic synapse, notice that the postganglionic neuron has the same receptor as the postganglionic neuron in the parasympathetic nervous system, the nicotinic receptor. And this is true for everywhere in the sympathetic nervous system. Now let's just focus on this part right here for now. At the postganglionic synapse, norepinephrine is released, and it can act on alpha 1, alpha 2, and beta 1. And now if we focus on this part, we can see that a preganglionic neuron can release acetylcholine at the adrenal medulla. And again, it's a nicotinic receptor, and what will happen is norepinephrine and epinephrine will be released, and it will travel through the blood. And they can act on receptors at that point. So, as discussed before, norepinephrine will act on alpha 1, alpha 2, and beta 1, but epinephrine can act on those three and beta 2, which is significant. And we'll discuss this further later in this lecture. Now there's one deviation from the rule that parasympathetics stimulate the muscarinic receptors, and that is the M3 receptor in the sweat glands only. In the sweat glands, the M3 receptor is actually stimulated by the sympathetic nervous system. So in a sympathetic response, there will be increased sweating, which makes sense because that's what we think of when somebody is in a fight or flight situation. Their sweating increases, even though it's a muscarinic receptor. But recall that the muscarinic receptors, as discussed previously, are still stimulated by acetylcholine, even though this is in a sympathetic channel. And now let's focus briefly on the skeletal muscle. Know that the neuron releases acetylcholine, and it will act on the nicotinic receptor, but for the muscular system, and that'll stimulate movement. An activity of the skeletal muscle is discussed in great detail in the musculoskeletal chapter. So now let's look at table 1.3, and this will show us all of the activities of these sympathetic receptors. Understand that alpha-1 causes mydriasis, or pupillary dilation. It also causes widespread vasoconstriction throughout the body. And this will increase blood pressure, and it will also increase venous return to the heart. Now, the reason for increased venous return to the heart is discussed in great detail in the cardiology chapter. Another sympathetic receptor is the alpha-2 receptor. And this will actually decrease norepinephrine release, so it will act as a negative feedback mechanism. So if you stimulate alpha-2, it'll actually decrease the sympathetic response at that neuron. But we're not going to discuss that much more in this lecture. The alpha-2 receptor can also decrease aqueous humor production. So when a patient has glaucoma, for example, which means, in layman's term, increased intraocular pressure, then it can actually decrease intraocular pressure. Now here are some of the big ones. When the beta-1 receptor is stimulated, that will increase heart rate and contractility and increase renin release from the juxtaglomerular cells of the nephron. And this is discussed in great detail in the nephrology chapter. Beta-2 receptor stimulation would cause vasodilation in the skeletal muscle specifically. So you'll notice that the alpha-1 causes vasoconstriction, and that's throughout the whole body, but the beta-2, also a sympathetic receptor, will cause vasodilation, and that's just in the skeletal muscles. The alpha-1 and beta-2 activities seem to be at odds with one another, but they're not actually. Think of the sympathetic receptor as overall causing vasoconstriction and increased blood pressure and increased venous return to the heart. When you think of beta-2, think specifically just the skeletal muscles. So its effect is limited to the skeletal muscles, and that is only when the skeletal muscles are really active. Moving forward, beta-2 receptors in the lungs will cause bronchodilation, and they will also increase aqueous humor production, which is the opposite of the alpha-2. And we're not going to go deep into ophthalmology in this lecture, so you can tuck that away for now, but know that alpha-2 decreases aqueous humor production and beta-2 increases it. And as I mentioned before, the M3 receptor in the sweat glands only will increase sweating, and this is a sympathetic receptor in the sweat glands. But everywhere else in the body, the M3 receptors are parasympathetic receptors. Now let's spend a little bit more time talking about norepinephrine and epinephrine. Direct sympathetic agonists will actually stimulate the sympathetic receptors. So that means anything that acts like norepinephrine and epinephrine can simply stimulate those receptors as though it were norepinephrine or epinephrine. Indirect sympathetic agonists will increase the sympathetic response by one of three ways: blocking reuptake of norepinephrine at the presynaptic neuron. And normally the reuptake of norepinephrine at the presynaptic neuron is a way to decrease the amount of norepinephrine in the synaptic cleft. So if you block that, you're increasing norepinephrine in the synaptic cleft, thereby increasing the amount of norepinephrine that can stimulate the sympathetic receptors. And we'll show this on the next slide to make it more clear. Another way that indirect sympathetic agonists work is by stimulating the release of norepinephrine from the presynaptic neuron. And this is probably the most intuitive one. If you want to indirectly increase the amount of norepinephrine in the synaptic cleft, you can increase the amount of norepinephrine in the synaptic cleft. And that's all this is saying. And the last major mechanism is to stimulate the release of norepinephrine and epinephrine from the adrenal medulla. And then these neurotransmitters will travel through the blood and act on the respective receptors. And understand that sympathetic blockers can block the alpha-1, alpha-2, beta-1, or beta-2 receptors. For example, alpha blockers or beta blockers, which are very relevant, especially in cardiovascular pharmacology. So here's figure 1.15 showing the sympathetic response on a more narrow scale. And to put this image in the correct context, know that this is a postganglionic synapse. And we know that because we're seeing norepinephrine and epinephrine. And if we were looking at the preganglionic synapse, we would see acetylcholine, not these sympathetic neurotransmitters. As you can see, norepinephrine is released from the presynaptic neuron, this on the left side, and it can stimulate alpha-1, alpha-2, or beta-1, these receptors in the red box. But also know that during a sympathetic response, the adrenal medulla will release norepinephrine and epinephrine. Both will travel through the blood and act on sympathetic receptors. However, Unlike norepinephrine, epinephrine can act on the beta-2 receptor as well. Another important point to know is that norepinephrine will be taken up again by the presynaptic neuron, this arrow here, and this will diminish the effect of norepinephrine, effectively decreasing the norepinephrine in the synaptic cleft. The overall point of this image is that during a sympathetic response, there will be increased epinephrine and norepinephrine, which will lead to stimulation of these receptors. And by referring back to table 1.3, we can see that if we have a sympathetic response, we will have increased blood pressure. Beta-1 stimulation would increase heart rate and contractility. Beta-2 stimulation would lead to bronchodilation or increased airflow, which makes sense because in a fight or flight situation, you want to be able to breathe the way you need to. You'll have increased respiration there. And then the AMP3 receptor will increase sweating during a sympathetic response. Now going back to figure 1.15, it's important to recognize that one can pharmacologically alter the activities of these receptors. And there are things that increase the levels of epinephrine and norepinephrine. And they can do this by increasing the release of these catecholamines from the adrenal medulla. These are indirect agonists, stimulate the release of epinephrine and norepinephrine. They can also stimulate the release of norepinephrine from the presynaptic neuron, or they can block the reuptake of norepinephrine at the synapse. Any one of these three actions would lead to increased norepinephrine and epinephrine. You can also block these receptors using alpha blockers, which, as the name implies, will block the alpha-1 and alpha-2 receptors. And these can actually be selective for alpha-1 or alpha-2, or be non-selective and block both indiscriminately. The same thing applies for beta blockers. You can block the beta-1 or beta-2 receptors. These can be blocked selectively or indiscriminately. And we're not going to dive into any more of the pharmacology here, but it's good to have a basic understanding of what would happen if you did block each one of these receptors. Lastly, there are direct agonists, and these can directly stimulate the receptors and act like epinephrine or norepinephrine, depending on the actual drug. For example, phenylephrine can stimulate the alpha receptors, leading to increased blood pressure, especially focus on alpha-1, because of the widespread vasoconstriction that alpha-1 stimulation would cause. And this can be helpful in a patient with hypotension. Now, there are so many drugs that can work at this interface. Our advice to you preparing for step 1 is not to get too caught up in the minutiae, but rather know exactly what each receptor causes. If you understand how the body would respond when the beta-2 receptor is stimulated, for example, one major outcome of which would be bronchodilation, then you will be able to do quite well on this material on step 1. And that doesn't mean that you can ignore pharmacology. It's very important to know the different names of the pharmacological drugs and their selectivity and all of the different effects, intended or unintended side effects that occur as a result of those drugs. But what is vital, more than anything, is to understand what these receptors do, which is the whole purpose of this lecture. So now let's do some questions to apply this. Would an indirect agonist that functions only by blocking the reuptake of norepinephrine back into the presynaptic neuron be able to cause bronchodilation in a patient experiencing anaphylaxis? Okay, so let's talk about what we know. We know that bronchodilation is mediated by the beta-2 receptor. And let's look at figure 1.15 again to explore this idea further. If you blocked norepinephrine from returning to the neuron, you would increase the amount of norepinephrine in the synaptic cleft, thereby be able to increase stimulation of the alpha-1, alpha-2, and beta-1 receptor. Would it be able to do anything to the beta-2 receptor? Nope. Recall that the neurotransmitter that stimulates beta-2 is epinephrine. So in answer to our question, would blocking the reuptake of norepinephrine cause increased stimulation of the beta-2 receptors? No, it would not. Now let's talk more about acetylcholine. Now acetylcholine, or ACH, is released into the synaptic cleft to act on muscarinic and nicotinic receptors. And these can be emulated by acetylcholine agonists such as bethanechol, carbachol, methacholine, and pilocarpine, meaning that these four agonists can act like acetylcholine. Now, acetylcholine is broken down by acetylcholinesterase, or ACHE, and this will modulate the effect of acetylcholine. Now, anticholinesterases will break down the acetylcholinesterase. This will lead to decreased breakdown of acetylcholine, leading to overall increased acetylcholine in the synaptic cleft. And this will allow increased muscarinic or nicotinic stimulation. Now here's figure 1.16, and we can see that acetylcholine is released from the presynaptic terminal. Acetylcholine can then act on the muscarinic receptors. Recall the three types we learned are M1, M2, and M3. Now, if this were a neuromuscular junction, not an autonomic junction, we could see that acetylcholine would act on a nicotinic receptor, specifically a nicotinic receptor for the muscular system. You'll notice the subscript M written. The elements I just described make up the foundation of this image. It is super important to know what activities that these muscarinic receptors are responsible for. But don't worry about that right now. We'll apply that in a moment. Now, before we dive into the applications of those muscarinic receptors, let's talk about what things can alter the neurotransmission of acetylcholine. Now, first, there's an enzyme called acetylcholinesterase, which we discussed in the previous slide. And these break down acetylcholine in the synaptic cleft, and this will decrease the amount of acetylcholine. Now, pharmacologically, there are ways to block this enzyme, leading to increased acetylcholine. So if you've decreased acetylcholinesterase, then you've increased acetylcholine. And this will lead to increased parasympathetic or muscarinic stimulation, or if it's a neuromuscular junction, it will lead to increased skeletal muscle stimulation. There are two basic categories of substances that can block acetylcholine. First are substances that irreversibly bind acetylcholinesterase, and these are called organophosphates. Now, these are extremely dangerous substances. In fact, these substances are designed to kill. They can kill bugs, pesticides, or they can be used to kill people in chemical warfare, for example, sarin gas. So now let's think about why this would be so deadly. You can imagine that if there were irreversible disruption of acetylcholinesterase, then acetylcholine would stimulate these receptors uncontrollably. For example, M3 receptor stimulation would lead to bronchoconstriction. Now imagine if there was massive bronchoconstriction. The patient would suffocate to death. Now we will come back to the damaging effects of organophosphates later in this lecture. Now let's go back to anti-acetylcholinesterases, but let's focus on the reversible kind. In certain situations, reversibly blocking this enzyme can allow enough acetylcholine to stimulate the receptors. For example, if a patient has constipation, giving a little boost to the M3 receptors by administering neostigmine, which will decrease acetylcholinesterase and increase acetylcholine, the M3 receptor can then be more stimulated to lead to more gut peristalsis. And this will get things moving in their digestive system again. But now let's move on to direct acetylcholine agonists, or direct cholinomimetics. Now these drugs work by stimulating the muscarinic or nicotinic receptors directly. Now some examples are methacholine or pilocarpine. Now these are very similar to the indirect agonists we discussed down here below. And if you need a little boost to the muscarinic receptors, these direct agonists can be a good option. So now let's do some questions to apply this knowledge. A patient is exposed to a chemical which leads to increased sweating, diarrhea, and a dangerously low heart rate. What single neurotransmitter in excess could lead to all of the symptoms demonstrated in this patient? Now the goal here is to break down the symptoms and identify the corresponding receptor. What receptors are responsible for these actions? Let's look again at table 1.3. Now this patient had profuse sweating, diarrhea, and bradycardia. The receptor responsible for sweating is the M3 receptor. And as mentioned earlier in this lecture, this is actually a sympathetic receptor. But we've included it here on this table to go along with the M3 receptor category. The receptor responsible for gut peristalsis is also the M3 receptor, and if overactive, could lead to diarrhea. And decreasing heart rate, as seen in this patient with bradycardia, would be mediated by the M2 receptors. So in answer to our question, what single neurotransmitter could cause all three of these symptoms, including sweating, diarrhea, and bradycardia? Well, it may seem obvious at this point, it's acetylcholine. And acetylcholine can act on all of these receptors. And what this question stem was alluding to is that this patient had organophosphate poisoning. And this will decrease acetylcholinesterase, which will increase acetylcholine, which has led to these symptoms. Now the question stem only provided a few symptoms of organophosphate poisoning: sweating, diarrhea, and bradycardia. The reality is that all of these activities could be hyperactive: meiosis, lens accommodation, lacrimation, bronchoconstriction, gastric acid secretion, increased salivation, and bladder contraction. There could also be decreased heart contractility. So now that we've answered that question, let's talk briefly about muscarinic antagonists. Now these do just the opposite of these other three groups we discussed in this figure: the direct cholimimetics, the irreversible acetylcholinesterase inhibitors, and the reversible ones. Now muscarinic antagonists can be used to block a muscarinic response. An example of a drug that does this would be ipratropium. Now this drug is useful for patients with obstructive lung disease because it will block the M3 receptor. And if you block the M3 receptor, you'll get overall bronchodilation. So let's do another example. Recall also that the M3 receptor can cause miosis, or decreased pupil diameter. So if you administer a muscarinic antagonist such as atropine, which blocks the M3 receptor, you'll get overall pupillary dilation, or mydriasis. And mydriasis is helpful in the ophthalmology clinic because this helps the eye doctor visualize the back of the eye because the pupil is now so dilated. So now let's summarize a lot of what we've discussed about acetylcholine back into this image, figure 1.14. So we've seen acetylcholine in excess act on M1, 2, and 3 receptors via organophosphate poisoning. We've also demonstrated the parasympathetic nervous system down here. You may also notice that acetylcholine acts on the preganglionic synapses of virtually every neuronal pathway, including the sympathetics. We can see these here. But you need to ignore these preganglionic receptors in this context. For example, in organophosphate poisoning, you're going to get excess acetylcholine. But it's best to imagine the acetylcholine being at the postganglionic synapse. So increased acetylcholine here would lead to increased M1, 2, or 3 stimulation. Increased acetylcholine here would lead to greater sweating. And increased acetylcholine at the synaptic cleft of skeletal muscle would lead to increased skeletal muscle activity. Now the reason we're just focusing on the postsynaptic cleft is beyond the scope of step 1. The point is that you just need to focus on the postganglionic synapses that acetylcholine acts on. This will correctly lead you to the correct symptoms. So now let's do a question to apply this. Now the previous patient, the patient with organophosphate poisoning, is treated with atropine to diminish the symptoms of organophosphate poisoning. However, the atropine is continued for longer than necessary and at a much higher dose than necessary. What symptoms could he develop? Now recall that atropine blocks the muscarinic receptors, which is helpful because initially they had organophosphate poisoning, which led to overactivity of the muscarinic receptors. But if we look at table 1.3, we can see what symptoms could occur with excess atropine. In other words, excess inhibition of these 3 receptors. Now blocking the M1 receptor with atropine could lead to decreased CNS activity, so disorientation. And M2 receptors normally decrease heart rate and contractility. So with excessive atropine, there would be a relative increase in heart rate and contractility. So in clinic, the patient would be tachycardic or have a rapid heart rate. M3 receptors normally cause a lot of bodily secretions through the GI tract, the eyes, and the skin. So we can expect the patient to be constipated because there's decreased peristalsis, there's going to be constipation. And with decreased ability to contract the bladder, there would be inability to urinate or urinary retention. And if the patient was unable to sweat as normal as a result of the atropine, then they could be red and hot, overheated in other words. Now regarding the eyes, this patient would have a hard time focusing on objects because the lens accommodation would be blocked. So you can say blurry vision. Now there is a mnemonic that many people have found helpful for remembering the symptoms of muscarinic block, or atropine use. And it goes like this: hot as a hare, dry as a bone, red as a beet, blind as a bat, and mad as a hatter. Now you may find this helpful, but for me personally, I like to know how the body works and then just deduce the symptoms from there, as we've just done on this slide. So in summary of muscarinic block, understand that muscarinic block means antagonism of the muscarinic receptors. This will lead to an overall decreased parasympathetic response, which means there's a relative increased sympathetic response. And this can be caused by muscarinic antagonists, such as atropine. And that concludes part 1 of this section.